Starting off with obstetric emergencies, the 2022 protocol for paramedic now moves into standing orders to treat eclampsia. So a seizing pregnant patient who is over 20 weeks, and we are now able to treat them with a very specific dose of 4 grams of magnesium sulfate IV, diluted in the 50 to 100 milliliters of normal saline over 10 minutes. So that is now standing orders, and that specific dose of 4 grams.
Megan, I have a question. So when we're administering, say, 100 milliliters of normal saline over 10 minutes, we're only going to reasonably be able to use a 10 drops per milliliter macro drip set. Is that correct?
Yeah, that's a really good point. And you only have to make that mistake once in lab skills to calculate that drip rate out for a micro drip set, which ends up being like 300 or 600, which is just insane. So you're absolutely correct. And thanks for that, that detail there, because it's really important to make sure that you're going to use a macro drip set when you're doing this drip. Thanks, Gail. All right, so let's talk about what exactly was that change. Formatting, a lot of different formatting, and took out a lot of the extra reminders that are really the bare minimum standard of care. So those extra reminders to that bare minimum standard of care has come out. The option to treat eclampsia with 4 milligrams of mag sulfate without contacting medical control. So that is a standing order. No maximum dose of magnesium. And then definitions were added in or changed a little bit for severe preeclampsia. We added in lower extremity edema and removed upper abdominal tenderness. So a point of reference there that those 6 different qualifications of severe preeclampsia, one of them was removed, upper abdominal tenderness, and lower extremity edema was added. Now we do have some additional definitions that I kind of started on already. Here they are. Eclampsia and preeclampsia don't occur prior to 20 weeks of gestation. And then eclampsia and preeclampsia, they also occur up to 1 month after postpartum. So we want to be aware with our patients about how exactly we're treating them, under what protocol we're treating them, and that even if they have given birth 3 weeks ago, that they could still fall and would fall into this protocol for eclampsia and preeclampsia.
Megan, I have a question about the pregnant patient who's maybe 12 or 14 or 16 weeks pregnant who's seizing. You know, we arrive on the scene, they're actively seizing, and we do find out they are not even nearly, 20 weeks gestation. So that would mean that they would fall into the regular seizure protocol. And being that a benzo is a category D medication where it could possibly harm the fetus, can we still use it?
Yeah, so with that, you can always call medical control to double check, but yeah, they fall underneath that protocol for seizures and not under eclampsia or preeclampsia. And it's a very good point to bring up, because we want to treat that seizure and we want to make sure that they are able to oxygenate, and that includes the baby as well. So we would absolutely treat them at that point, and we would treat them with benzos.
Okay, so I guess the benefits outweigh the risks at that point.
That's correct.
Okay, thank you.
Of course. So now into emergency childbirth, there's been an addition to state that we're delaying the clamping of the umbilical cord for up to a minute, only a minute after an uncomplicated delivery. The reason for that being that it is definitely better for the baby, decreases the chances of anemia, and helps the baby overall. So in moving with good medical practices and research, delaying the clamping of the umbilical cord for up to a minute for an uncomplicated delivery. And then also the addition of placing the neonate onto the mother's chest if it is safe to do so. So those 2 things were added into emergency childbirth. When we move into some of the complications for prolapsed cord, We change the position of the mother. So we're placing the mother in a knee to chest position, and then encouraging the mother not to push as well in a prolapsed cord situation. For shoulder dystocia, those wedged shoulders from the baby in the birth canal, we are talking about, or wedged against the hips, we are encouraging the mother not to push. So in addition there, and we're another addition, placing the mother in that different position, the knee to chest position. And it may also require to have additional providers helping to have that hyperflex position. That hyperflex position of the legs is medically known as the McRoberts maneuver. So a picture of that, just to really be able to visualize what we're doing, we are helping to facilitate a better alignment. And as we are tilting the pelvis, that better alignment will hopefully allow for a little bit more room. So McRoberts position is the position that we're looking to assist the mother with. Additionally, Trendelenburg position, or placing the head of the bed lower than the legs, or the head of the stretcher wherever you are as much as possible, if that's a possibility. And then we're also applying firm, steady suprapubic pressure, and we're avoiding fundal pressure. What that looks like is this would be suprapubic pressure. Fundal pressure would be placing pressure here or here. So we want to make sure that we are doing what this photo illustrates. We want to make sure that we are giving pressure in the right position to help the mother move along in the delivery. In addition to the protocol, if the maneuvers fail to deliver the neonate, then reposition the mother on her hands and knees and guide the head downward to aid in the delivery of the upper shoulder. So more additions to that specific complication. Some additional key points and considerations: miscarriage occurring at less than 20 weeks of gestation. And then turtle sign, just defining what that turtle sign is, when the neonate's head retracts back into the vagina, and that is a very strong indication that the complication you're dealing with in childbirth is that shoulder dystocia, and to move into the protocol for treating the shoulder dystocia. One last point before we watch a video about McRoberts maneuvers. The couple of last points is that we are not aggressively suctioning anymore. So we want to make sure that when we are treating neonates, that we are not aggressively suctioning.
A common complication that can happen during childbirth is shoulder dystocia. Shoulder dystocia occurs when the anterior shoulder of the fetus becomes lodged behind the pubic symphysis. An example that is used to describe this would be a truck driving through a low-hanging bridge. The front of the truck represents the baby's head, the cab represents the baby's shoulders, and the bridge represents the pubic symphysis. If we were to force the truck through the low-hanging bridge, there would be damage to either the truck, bridge, or both. The most common maneuver to resolve shoulder dystocia is known as the McRoberts maneuver. The American College of Obstetricians and Gynecologists Guidelines recommends the use of the McRoberts maneuver as the initial maneuver to resolve shoulder dystocia. It is a simple, logical, and effective maneuver that has been proven to resolve a considerable amount of shoulder dystocia without additional obstetrical maneuvers. How does a provider recognize shoulder dystocia? Turtle sign is a clinical sign of fetal shoulder dystocia. The head bobbing, emerging, and then pulling back has a similar look to the turtle going in and out of its shell. How to perform the McRoberts maneuver. Both maternal feet are pushed towards the head. This action results in hyperflexion of the hips and knees. This adjustment will cause some displacement, allowing the shoulder of the unborn patient to move from the pubic symphysis to facilitate delivery. Suprapubic pressure. The additional use of suprapubic pressure in conjunction with the McRoberts maneuver allows for a greater success rate of delivery. The technique is similar to that of chest compressions, except the pressure is applied suprapubically and not over the chest, also not over the fundus. This will direct the pressure on the anterior shoulder both downward and laterally. Essentially, the pressure is pushing the unborn patient's shoulders downward to clear the pubic symphysis and ultimately facilitate delivery when used in conjunction with the McRoberts maneuver.
We're going to talk now about neonatal care and resuscitation. And this protocol will apply to neonates within 1 hour after birth, and it's for all provider levels. First thing we're going to do is warm, dry, and stimulate the neonate. And in most cases, we're going to wait for about 1 minute after birth before we do anything aggressive in terms of resuscitation. Studies have shown that most neonates will recover on their own without any intervention. So this will reduce any risk of resuscitation trauma. So after 1 minute of birth, assess the neonate. If there's poor respiratory effort or poor tone, stimulate breathing by rubbing the back and gently flicking the soles of the feet. We're going to ventilate at a rate of 40 to 60 breaths per minute on room air only at this point if the neonate has any of the following: persistent central cyanosis, respiratory rate less than 30 per minute, and a heart rate of less than 100 beats per minute. Keep in mind now that these numbers are all aligned with the neonatal ALS and PALS. Okay, now 2 minutes after birth, we're going to assess the neonate's heart rate and perform the following. If the heart rate's greater than 100, we're not going to do anything additional. We'll just continue with supportive care and continue assessing the neonate every minute. If the heart rate's between 60 and 100 beats per minute, or there's poor respiratory effort, we'll just continue with ventilations. And again, monitoring that rate every minute or so. The heart rate's less than 60 beats per minute. After 30 seconds of providing good ventilations, and remember, those ventilations are only to see chest rise. We've got to be real careful just to provide ventilations to see chest rise with the neonate. If the heart rate is persistent under 60 beats per minute, now after 30 seconds of those good ventilations, start compressions while continuing with the ventilations in that 3-to-1 compression to ventilation ratio. Reassess the neonate every minute and perform the following. If the heart rate's greater than 60 beats per minute, don't perform compressions, but continue ventilating at a rate of 40 to 60 until the heart rate is greater than 100 beats per minute. You can also supply some supplemental O2, but don't perform ventilations or compressions if you have a heart rate greater than 100 and there's no longer that persistent cyanosis and respiratory effort is good. Again, keeping in mind throughout this whole process, while you're doing compressions and ventilations, you should still be monitoring the baby to make sure that you're maintaining warmth. Let's move on now. At this point, you might be thinking, okay, I want to obtain an O2 set on the baby. Keep in mind that the most accurate O2 set on a neonate is going to be obtained in the right hand. And the reason for that is, remember, fetal hearts have a patent ductus arteriosus. This normally is going to close between 12 and 72 hours after birth. But there's a reason why we want to go for the right hand. So the patent ductus arteriosus allows mixing of the blood to supply oxygen-rich blood to the lungs in utero. Obviously, the baby's not breathing at that point, so this is how the lungs are being oxygenated. But this usually closes after birth, and it's not a problem, but it could confuse you if you have the pulse ox on the left hand. So during each heartbeat, blood is going to flow from the left ventricle into the aorta, then out of the right brachiocephalic artery, and supplying the right carotid and right subclavian. This is what's going to supply the right hand. Blood's also going to flow out of the right ventricle into the pulmonary artery and also through the open ductus arteriosus mixing with oxygenated blood. So now you've got deoxygenated blood and oxygenated blood mixing, and that's what's supplying the left hand and the lower extremities. So that is going to give you a false low pulse ox reading. So again, the right hand, you're going to get a more accurate pulse ox. The left hand, it could be up to 10% less than it would normally be. And let's take a look at those pulse ox readings. After birth, 1 minute, a normal pulse ox would be between 60 and 65% for the neonate. 2 minutes, 65 to 70%, 3 minutes, and so on. And you'll see that it's going to go up 5 to 10% after each minute after birth. Until about 10 minutes after birth, you should get a good reading between 85 and 95%. And again, on the right hand. Okay, the proximal tibia now is the only site acceptable for IO access in the neonate. Keep in mind too that you're better using a manual IO device on the neonate. It's just too easy to drill through the tibia. And even when you're using the manual device, be very careful not to go through the tibia, and don't go all the way up to the hub in most cases with the neonate, because again, you're going to end up going through the tibia, possibly causing compartment syndrome and some really serious, potentially long-term problems for the neonate. And finally, the heart rate is best assessed at the umbilical stump. So you want to go to the base of the umbilical cord close to the body and gently compress, and you should be able to feel a pulse there. You can also use a stethoscope to auscultate the heart rate substernally as well.
For asthma, COPD, and wheezing in both the adult and pediatric patient, some additional treatments and some minor changes. For the adults and pediatric patients over 2 years, we can also now give dexamethasone IV or dexamethasone IM or PO. So that gives us some additional options to give stabilizing drugs after we treat the immediate problem with other medications. 3 additional doses of albuterol may be given on standing orders. Epinephrine and a weight-based dose may be given, and then after the initial dose may be repeated in 20 minutes. Children less than 2 years with their first episode of wheezing most likely have viral bronchiolitis, in which case there is no role for some of our standard treatments for asthma in bronchiolitis. So remember, less than 2 years old, first episode of wheezing, you're probably not dealing with asthma, but instead viral bronchiolitis. The management of bronchiolitis will include supplemental oxygen, intravenous fluids if dehydrated, or ventilatory support if needed, not some of the other drugs that we would normally give for wheezing. For children greater than 18 months, for who there is a history of albuterol use in the past, or a strong family history of asthma, atopic dermatitis, eczema, albuterol may be administered, followed by an evaluation for clinical response. So a little bit of clinical judgment can be applied there. In cases of stridor, croup, and epiglottitis, which are always challenging, administration of high concentration blow-by oxygen, preferably humidified, delivered by nasal cannula or a face mask, held 3 to 5 inches from the face, as tolerated, is an acceptable treatment for all provider levels from CFR on up.
Heat emergencies for the adult and pediatric patients. You will administer crystalloid fluids, 20 milliliters per kilogram via the IV route, up to a maximum of 2 liters. For cold emergencies for the adult and pediatric patient, you will also administer crystalloid fluid, but warmed if available, at 20 milliliters per kilogram via the IV route, up to a maximum of 2 liters.
For a child with stridor at rest, paramedics have the option of delivering epinephrine by 2 different methods. First option is to give standard L-epinephrine, at 3 milligrams, which is 3 milliliters of a 1 to 1,000 concentration via nebulizer, or as another option, 2.25% racemic epinephrine, 0.5 milliliters mixed with 3 milliliters of normal saline. Either option is acceptable. For overdoses not resulting from opiates, which of course, as we mentioned, are covered in a separate protocol now, diphenhydramine is now an option for overdoses, particularly tricyclics, in which there is a dystonic reaction. For overdoses that result in a prolonged QT segment, as witnessed on the EKG, we have the medical control option of administering sodium bicarbonate for suspected antidepressant medication overdose. These are some of the medications, mostly psychiatric medications, which will produce sometimes dystonic reactions. And dystonic reactions, as most of you know, dystonic reactions will often present as abnormal contraction of the extremities or disfigurement of the face, swelling of the tongue, etc. These are very common reactions for overdoses from tricyclic antidepressants. Prolonged QT segments, of course, need to be evaluated by EKG, which means if you're dealing with these kinds of overdoses, we should be taking EKGs. Measuring the R wave to the R wave, and then looking in the middle to see if the T wave is past that midpoint is an indication of a prolonged QT. Prolonged QT segments have a potential for creating dysrhythmias, including torsade, that can obviously be lethal. Keep an eye out, measure the distances, and decide whether or not the QT segment is prolonged and if you need to respond. In sympathomimetic overdoses, cocaine, amphetamine, stimulants, etc., we have the options under medical control to deliver any of 3 benzodiazepines, midazolam, lorazepam, or diazepam, and each of these can be given via IV, intranasal, or intramuscular routes.